data on TCH compared to anthracyclines. And this will be a matter that we can debate always in the manuscript. We did discuss at this meeting the fact that there is a potential an alternative when patients don't want to have a taxane. So let's see what is your opinion. Vinorelbine can substitute a taxane if the patient refuses the taxane. Yes, no, abstain.
But this is still adjuvant treatment.
In the adjuvant setting, yes. It's wonderful. We had everyone answering. So there is a slight majority vote in favor of vinorelbine, and 1/3 that say no, 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 we don't have the final adjuvant data.
Excuse me, is this an evidence-based?
No. The answer has to be an evidence-based.
The answer has to be whatever you believe is what you will do for a patient when the patient says flatly, no way, no taxane. My cousin lost all her nails because of taxanes. So then what in the world do you do if you believe that chemotherapy needs to be added?
Yeah.
Okay, so question number 13.
Again, in HER2 positive, hormonal positive patients, again, tricky one, with tumor size less than 5 millimeter, node negative, what to use? Adjuvant endocrine therapy alone, adjuvant chemo with trastuzumab, then endocrine therapy, adjuvant endocrine with anti-HER2 without chemotherapy. We'll start with the first one. So adjuvant endocrine therapy alone. Again, this is a tricky one where there is no right or wrong answers. We'd like to know what is the practice in this gray zone.
There is no evidence-based answer, okay?
Absolutely, yeah. Okay. So almost... yes, Dr. Ala?
Can we just answer this question while the three options are almost there, just to know the preference among the experts between the three options, and then ask it in the way you're doing A, then B, then C?
Okay, let us finish this one and then we re-vote on that one. We'll finish these sequences and come back to your suggestion. Second option would be adjuvant chemo with trastuzumab, then endocrine therapy. So you are actually throwing the book on them, everything. Chemo, anti-HER2, and hormonal therapy for 0.5 centimeter, node negative, HER2 positive breast cancer. Okay, almost third said yes. Interesting. Third option is adjuvant endocrine therapy, so no chemotherapy, with anti-HER2. Please start voting. All right. Okay. Interesting.
Can I make a comment, please?
Yes,
Can
Dr. Naji, go ahead.
Yes. I think just to clarify for everybody in the audience that the study that was reported by Tolani, the adjuvant APT, adjuvant paclitaxel trastuzumab, paclitaxel for 12 weeks and trastuzumab for 1 year, did include about, I think, 80 or 90 patients who were less than 5 millimeters. So it is okay to use that regimen with trastuzumab.
Actually,
okay.
in that
Did it, differentiate between ER positive and ER negative in that study?
No. Yes, the survival was very good for this group, but I mean, without treatment, you may have the similar survival. That's the argument.
Yeah.
Can you
Okay.
vote it? Can you vote it like Dr. Alaa mentioned?
We
the
would
three
like
options
now.
together.
Okay. We would like now to vote this one, assuming that A, yes. We have three options. Okay, so we will vote it. Okay. Now we will assume that A is the first option, B is the second option, and C is the third option of the question. So A is adjuvant endocrine alone, B is adjuvant chemo and anti-HER2, then hormonal therapy. No, please leave I'll read the questions.
Yeah,
and C is the adjuvant endocrine with anti-HER2 without chemo. So forget about, so ABC is, again, A is adjuvant hormonal, C adjuvant hormonal and anti-HER2, and B is the three of them. Please start voting. Okay, 4 did not vote. So 48% have used adjuvant endocrine alone, 28%, the three treatments, anti-HER2, hormonal therapy, and chemo, and almost a quarter used endocrine therapy with anti-HER2 alone. Okay, I think thank you, Naji. We will comment on that as well. Next question.
Okay, question 14. In HER2 positive, hormone receptor positive, now it's still less than 5 millimeters or 5, PN1 microscopic. Same questions. This is really tricky, huh? Okay, 14A, adjuvant ET alone. Yes, no, abstain. Let's move to 14B. Adjuvant chemo with trastuzumab, then endocrine therapy. Everything. Yes, no, abstain. Okay. 14C, adjuvant ET and trastuzumab without chemotherapy. Yes, no, abstain. Okay. Do you want to vote again as for the previous question?
I think we should.
Okay, so we go back to question 14A, and we will revote as we did in previous one. A or yes means adjuvant ET alone for 5 millimeters or less, PN1 microscopic. B is adjuvant chemo, trastuzumab, endocrine therapy, the whole thing. And C is trastuzumab endocrine. So go ahead.
You don't wish to have any comment on the N1 MAC on as...
Yeah, I was going to ask for
effect?
the comment right after we see the vote. Let's see.
Does
what
it affect
happens.
prognosis actually?
Okay, so we have 48% in indicating that they would like to have everything just because there is a microscopic positivity in the sentinel lymph node.
I think we need to have some comments.
So anyone wants to comment on how much a few cells microscopic invasion of a lymph node should really tip the balance as it seems to do?
Dr. Nihal, please. Yeah, go ahead.
You know, I'm wondering about your comment about those who said yes. And number two, the definition of microscopic disease is more than 200 microns.
Can I say something? Yes. I think if you have a less than 5 millimeter lesion that has already gone to the axilla, even microscopic, you might consider it as a bad prognostic sign, worse prognostic sign.
Is there any evidence? Is there any evidence to suggest that these patients?
It would be impossible to do any clinical trial with those patients.
You know, the NI, the micro actually in the guidelines did not change any recommendations if we want to follow the evidence. I fully, take your point on board. Yes, Doctor.
The last NCCN guidelines put Herceptin in a patient with NMIC, 2016.
As an option or as a must?
No, not an option.
So that's where we are. There's no doubt that the more we see indication that this is really an aggressive disease, as we suppose it is anyway, the more prone will we be to give the whole treatment. I think this explains the switch of the vote. So we can now go to question 15.
In HER2 positive, hormone positive, this time the tumor is 0.6 to 1 centimeter, and node negative or microscopic nodal involvement. The same options. Endocrine alone, chemoendocrine and anti-HER2, or endocrine and trastuzumab. So we'll start with the first one. So we are talking now about slightly larger size, either node negative or microscopic nodal disease. Okay, expected. Next, now adjuvant chemo, trastuzumab, then hormonal therapy. Okay, almost 3/4 are on for the full treatment. Endocrine and Herceptin only, no chemotherapy. Okay, I think we can move on. Shall we repeat the same or no need? No. Okay. Next question.
Okay, now we reach the centimeter, and here the option of doing only endocrine treatment has been dropped, and you have the choice between everything or adjuvant endocrine with trastuzumab without chemotherapy. So let's have a vote for 16A, adjuvant chemo with trastuzumab and endocrine therapy. Yes, no, abstain. Okay, 100%. 16B,
Should be 0.
adjuvant ET with trastuzumab without chemotherapy. Okay, someone says, well, it might be an option if the patient really refuses the chemotherapy, which of course is always an option. Okay, question 17.
Now it's hormone negative, ER negative, PR negative, HER2 positive, 0.5 centimeter, node negative disease. There's one more option here, is doing nothing. So no adjuvant treatment, Herceptin alone, chemotherapy alone, chemo with Herceptin. We'll start with the first one. Nothing to be given as adjuvant. HER2 positive, hormonal negative, 0.5 centimeter, node negative. Okay, 20%. And I've seen vote, the highest number, 30. So someone maybe have voted twice. Okay, B, Herceptin alone. Okay, 13.8 think it might be the case. And C is chemotherapy alone for HER2 positive disease. Hormonal negative, small tumors, 0.5 node negative. All voted. And self-explanatory. Last option is chemotherapy with trastuzumab. Okay, interesting. Next.
Okay, now we increase the size of the tumor. No, we don't increase the size of the tumor. It's always very small, but now it has the PN1 mic. All 4 choices. So let's see if there's any change in these choices. It's going to be difficult, I believe. No adjuvant, 18A. Okay, everyone voted. Okay, some people say even with microscopic disease, then well, you could do no adjuvant. Okay, next question, 18B, trastuzumab alone. Okay, so then 18C is chemotherapy alone. The musicians are preparing for the dinner. Okay. Then 18D, like David, chemotherapy with trastuzumab. Less than 5 millimeters, microscopic.
I'm
Okay, now the votes are in. I can take the comment. Yes, please.
Yes, I'm sorry again to come back to that point. I mean, the idea is to know from the panelists how would they treat this patient. Yes. So answering the same slide at the beginning rather than just going to A, B, and C, and D, how would they come with any interpretation thereafter?
Okay, so we can go back. Can we go back to question 18A? And yes, which is going to be, I will read out. Oh, actually, we have a problem technically because we have 4 possible answers. Is that feasible for technicians?
Sorry, for you at the back, can we have A, B, C, D in the answers, or we can't?
So, Albert, can we go for 4 possibilities? ممكن نعمل 4 اختيارات؟
في سؤال رقم 18. We need 4
Possible or not?
possibilities.
There is no possibility.
Okay, take your time. If you just make A, B, C, D, that's all.
Till then, can we just have an idea about what is the risk of recurrence of this patient at 10 years?
I think we need further data for this patient.
And then, by extrapolation, the regimen of chemo with trastuzumab will reduce this recurrence by 40%. Then we can put a sort of quantified benefit of the treatment. The risk at 10 years is in the range of 10% for this patient, for instance. Do you have any other higher risk? 10 to 15%, right?
Do we need another data for this patient? Or this is enough? I mean, degrading the age of the patient.
And vote now? Okay.
Okay, we can vote now. The answer is about the other factors. Of course, you have to take everything into account, but let's take that this is the standard age, median age, no problem patient, and you just have to decide on the basis of what you have here available. So you have 4 choices that you'll be voting on. No adjuvant treatment, trastuzumab alone, chemotherapy alone, chemotherapy trastuzumab. What is your preferred choice? Let's see how they show it. You'll see what happens. Okay, clearly the majority would go, and we really appreciate. Thank you very much to the technicians. At the last moment, you were able to deal with our requests.
Matti and Ahmed, my question is like this. What is the risk of recurrence for this woman if left untreated? That's the question. At 5 years, do we have any figure in mind?
I think less than 10%.
Okay, fine.
Yeah. But, you know, what we are trying to catch up here is the practice, what's happening.
Yeah, no, that's for the audience, because we're going to reduce this recurrence by 40% anyway if we give chemo and trastuzumab.
Yeah.
Okay, let's move now to question 19.
Again, yes, it's HER2 positive, hormonal negative. The size now is 0.6 to 1 centimeter. Again, either N0 or micro-involvement. Chemo alone or chemo with trastuzumab.
We can make the vote.
I think we can make the vote on this one.
Yes, yeah.
لو سمحتوا, technicians, can we do the same? No. Yes, we can vote on this one, A and B, and if you can show us.
خلاص. Yeah.
Not use C. Okay.
Yeah. Can we start voting on this now? Okay. Thank you, Ala. I think that is a more meaningful way of getting what's happening. Okay? All right, so the vote is either chemo alone or chemo with Herceptin. The only change from the previous one is slightly larger size, but still less than 1 centimeter.
With chemo, we mean only trastuzumab plus trastuzumab plus paclitaxel.
No.
We don't mean AC.
Chemo, any chemo you want to use on this one.
No.
Okay, it's 100% for the chemotherapy along with the trastuzumab. Naji, I believe that your question, which is important, was in part answered in the previous when we said that in some patients with some characteristics that we discussed, a taxane plus trastuzumab, eventually vinorelbine plus trastuzumab, is something that can be done rather than having everything thrown at the patient. So we go now to question 20. Question 20. In all lymph node positive HER2 positive patients, adjuvant trastuzumab should be given for 1 year. There will be a choice at the next question. Yes, no, abstain. But what is the ideal?
Next question. Now, in financially restricted situations, adjuvant Herceptin duration could be restricted to 6 months.
Could be restricted by who? The Minister of Health?
By the physician.
But physicians cannot decide that. It's
by the guidelines.
Healthcare authorities that have to decide this.
Restricted by the guidelines, by the local guidelines. Okay.
And we assume that we are talking about lymph node positive disease here. Okay, so more than half think yes. Again, interesting to comment on later on. Next question.
Okay, we are here still in the adjuvant situation, not neoadjuvant, adjuvant. Pertuzumab containing regimen can be administered to patients with a T2 or worse or N1 or worse HER2 positive early breast cancer. Yes, no, abstain.
Can or must?
The adjuvant setting.
Can or must?
The question is can.
Okay.
Interesting to know if you can do that. In Switzerland, we cannot.
Oh, that's interesting. Can we ask one from the A to comment, please?
Can we see if anybody knows the results of the affinity trial?
Sorry?
Affinity trial.
Yeah. No one knows.
The question is can, not must.
And I think this is reported in the NCN guidelines that we can do this.
Adjuvant?
Yes. Yes. In the NCN guidelines, in the adjuvant setting, there is like a statement